Thank you, Chair, for the introduction. I'm Dr. Antonio Pallotti, Research Supervisor in Technoscience and Head of the Computational Graphology Laboratory at the Department of Human Science and Promotion of the Life Quality at San Raffaele University of Rome, PhD student at the Department of Management and Law, Tor Vergata University of Rome. The work that I will show you, as in the title, is a collaboration under my supervision, Dr. Valentina Camamilla at the Department of Movement, Human and Health Science at the For Italico University of Rome, Prof. Emanuele Piuzzi at the Department of Information Engineering, Electronics and Telecommunication at La Sapienza University of Rome. Let's start with a brief introduction in which we will talk about the context in which the project develops and its goals. During the last few years, health services around the world have had to deal with the emergency caused by COVID-19. In this period, in order to reduce the infection, hospitals had to interrupt some therapies, leaving patients without treatment. To solve the issue, health services developed telemedicine services to follow patients at distance. But what is telemedicine? The World Health Organization defines the telemedicine as delivery of healthcare services where patient and providers are separated by distance. One of the branches of telemedicine is telemonitoring and telerehabilitation. In particular, in the context of COVID-19, telerehabilitation services were developed for disease affecting the cardiorespiratory system and to COVID-19 disease, to provide remote rehabilitation to people distant from the usual therapeutic setting. Naturally, wearable device and IoT frameworks are key elements for the development of telerehabilitation and more in general telemedicine services. In fact, this kind of solution need to signal and data acquired directly to the patient and then sent to physicians or to the rehabilitation team in order to evaluate the dispensed rehabilitation program, its effects, and the impact on the patient and the response of him. Conventional rehabilitation protocols are based on monitoring vital parameters, such as heart rate, and they propose respiratory exercise and motor reactivation exercise. Rehabilitation structured in this what shows positive effects such as a reduction in muscle weakness and dyspnea, a better readaptation to muscular effort, and a return to activities of daily living. But the traditional approach is generally operator dependent and it is influenced by the patient attention in complying with the proposed rehabilitation program when it's carried out at home, in absence of the rehabilitator. On the other hand, telerehabilitation services are defined in the national healthcare system as the remote provision of services intended to enable, restore, improve, or otherwise maintain the physical functioning of people. By using telerehabilitation services, the cost-benefit ratio is improved because the effects of conventional rehabilitation are preserved, such as high level of physical activity, but some barriers are broken down, such as travel to medical centers. Finally, the healthcare costs related to the patient hospitalization will be reduced with the possibility to increase the number of users. And also, thanks to the use of wearables and IoT systems, a real-time monitoring is possible. This means that medical staff will be able to better monitor adherence to the rehabilitation protocol and will be able to evaluate rehabilitation results in terms of quantitative parameters. In this presentation, we propose the architecture, infrastructure, and the essential elements of a rehabilitation framework, including quantitative movement monitoring based on wearable devices. Their data will be transmitted to an app used by the patients and a web platform for the rehabilitation team. This service will be based on the Internet of Things concept, IoT. This study focused on the presentation of the wearable system, and our main contribution consists of a feasibility study performed to assess the minimum number and placement of sensors required to monitor quantity and intensity of a selected list of repetition exercises. In the following slides, I will show you the wearable system that will be used for the telerehabilitation framework. The system is composed by a Sensoric shirt, an IMO belt, and by two Sensoric socks. The Sensoric shirt showed in this slide will be used to monitor electrical cardiac activity, heart rate, respiratory rate, oxygen saturation, and body temperature. These parameters are crucial to monitor the subject's health status when performing physical exercise. One lead ECG will be measured using the proto-central ADS 1293, placing two electrodes on the chest near the arms and one on the right side at the level of the abdominal area. The ECG monitoring will act as an alarm tool so that the patient can safely perform the exercise protocol. The sensor was selected to be suitable for monitoring exercise since it is equipped with motion artifact compensation. After that, the shirt integrates two devices of a smartphone company in order to monitor the heart rate and the oxygen saturation, 18-bit resolution, and a digital thermometer positioned under the armpit. One wide 12-bit resolution, less and more 0.5 degrees accuracy. Finally, the respiratory rate is collected with a 3-axis accelerometer. The analog device is MEMS, detecting the acceleration resulting from chest movement. All these sensors are connected to a microcontroller board, Arduino Mega. Data will be transmitted via the Bluetooth module, allowing the communication between the Arduino board and the patient's app. The proposed Sensoric socks are the system prototype developed by our research group. Each sock integrates four force sensors. The flexi-force resistive sensor able to detect the force applied in the contact area over 445 Newton. These sensors are positioned respectively under the first, second, and fifth metatarsal head and under the heel. The socks are also integrated a magnetic inertial measurement unit (MIMO) sensor, placed few centimeters over the malleolus. These sensors are used to determine the movement of the patient with the possibility to program the full-scale range of accelerometer gyroscope. These sensors are all connected and powered by an Arduino Nano 33 Sense that integrates a low-energy Bluetooth module used for the communication with the transmission unit. At the end, the belt equipped with a 9-axis MIMO, so 3-axis accelerometer, 3-axis gyroscope, and 3-axis for the magnetometer. The sensor is integrated in an Arduino Nano used also for the communication with the transmission unit. The Sensoric belt is proposed to monitor posture and balance control that is a critical aspect during the rehabilitation protocol exercise, especially for elderly patients and for those suffering from chronic respiratory disease or long COVID problems. The transmission unit is composed by a mobile application designed using the online Meetup Inventor tool. The application collects all the data from the wearable devices through the Bluetooth communication with the Arduino boards, and then it transmits and stores data both locally on the mobile phone and on the Google Firebase database. The app uses the mobile internet connection or a Wi-Fi connection to store the data on Firebase. The system guarantees the secure transmission of data with private credentials, and the Google Firebase is certified according to the main privacy and security European standards. As a preliminary action to development of the rehabilitation service, a feasibility study was performed on a female healthy participant. For this feasibility study, commercial MIMO sensors designed to capture movement were used. In particular, the experimental setup is composed by 6 MIMOs placed in the different body location displayed on the stick man in the slide. We have 4 sensors on the trunk, in particular on the sternum, ribs, and pelvis, one on the wrist, one on the thigh, and one on the ankle. The commercial MIMOs are the blue trident of Vicon with a sampling frequency of 500 Hz, recorded using the REHACT-EU Vicon app. The exercise protocol includes strengthening exercise for the upper and lower limbs, aerobic and breathing exercises, and when performed in different settings. Lying down, sitting in a chair with and without a backrest, standing up with or without a reference, couch or wall. In the slide, it is possible to see the pictures of the participants performing some exercises. The aim of the feasibility study is to verify first of all if and which sensors are adequate to capture the patient movement, but after that it is fundamental to understand which sensor can characterize the movement, quantity, and intensity while the participant is performing the exercises. So we are searching for the minimum sensor setup that must be used in the IoT-based telerehabilitation system. In the slide, the entire system is shown combining the prototype wearables and commercial MIMOs, with the visualization also of the ECG, temperature, and oxygen saturation signals, used not only to monitor the exercise but also as safety and alert signal in the worst pathological cases. Data acquired by the six trident MIMOs were processed using MATLAB. The first step of the processing is the filtering operation, done using a fourth-order Butterworth filter with a cutoff frequency of 0.5 Hz. In the slide, 2 samples graphs show the effect of the filtering operation. After that, the processing follows with the repetition number detection. That is based on the peak detection, using empirically determined thresholds. Naturally, after the peak detection, for the quantity assessment, for example, number of repetitions done in an exercise, the results obtained with the trunk sensor were compared with the actual repetition obtained by the sensor chosen as a reference for each specific exercise. In this graph, there is a comparison of 2 signals acquired by the rib sensor and by the thigh sensor during a half squat exercise. In particular, we have on the top the ribs gyroscope signal in which 5 repetitions are detected, while below the thigh gyroscope signal is shown with also in this case 5 peaks detected and so 5 repetitions counted. At the end, in order to have an intensity assessment and also to be sure that in the peak detection operation only identifies the exercise repetition and not other non-informative peaks, the correlation operation is carried out. In particular, the intensity assessment was associated with the trunk sensor having a similar shape as that of the reference sensor, with a correlation higher than 0.4. The table shows the results of the visibility of the detecting the correct quantity of repetition and the correct intensity from trunk sensor as compared with relevant reference sensor. In particular, the quantity repetition are indicated with the Q letter and is considered correct naturally if the number of repetitions counted by the analyzed trunk sensor is equal to the repetition counted with the reference sensor with a tolerance of less more 1 repetition per exercise, while the intensity is respectively indicated with the E letter and are seen with green, and so correct the trunk sensor that show a correlation coefficient higher than 0.4 with respect of the reference sensor. We can observe that the trunk sensors have very good results in tracking and capture the respiratory exercise and standing exercise. They have good potential regarding the acquisition and correct detection of upper limb exercises. On the other hand, the low sensitivity of the trunk sensor for seated lower limb exercise is clear. Naturally, these are the results of this pilot study actually in progress and development. This preliminary investigation suggests that using the sensor placed on the trunk, it is very difficult to monitor the exercise of the lower limb. To solve this issue, it is necessary to include the ankle sensor to acquire data on lower limbs exercises. Respiratory exercises must be tracked from the ribs, both while sitting and lying down, and it is promising to track also exercises if combined with appropriate exercise selection. In conclusion, we define the final minimum sensor setup configuration shown in the slide, both on a stickman but also yet integrating the wearable proposed system. The setup includes only 3 sensors positioned respectively on ribs, pelvis, and ankle. Alongside the wearable system, there are also some qualitative signals collected during the execution of a rehabilitation protocol exercise using commercial sensor. Naturally, the next step in this study is the use of only the wearable device that integrate the MIMOS sensor of the setup identified in this pilot study. So in conclusion, the minimum MIMO setup has been identified to integrate and use it in the proposed wearable system, observing quantitative data acquired during the rehabilitation protocol performed in this pilot study. Naturally, the future developments are many. First of all, using the proposed wearable system in place of the expensive commercial sensor. After that, very important is to enlarge the population most requiring data on elderly and on people who need rehabilitation, so on patients. And at the end, other future development regards the use of the entire EOT proposed framework for a complete monitoring of both vital signs and rehabilitation quantitative parameters in people suffering from respiratory disease or COVID-19, with the online and real-time data sharing between patients and physicians or rehabilitation team and online data processing. This is the full team that works on the research project. Thank you for your attention.